So then we'll do the ischemic changes, just to do the lactate, to do the ischemic changes. Okay. I will try to find some of my notes for pediatrics. If I do find it, then I will go through them along with it. And yeah, I'm very reluctant to share my notes with anyone because I don't feel like that's the point where you should be studying from. I mainly want you to focus from the Toronto notes. That's why I don't feel like sharing my notes with anyone. But if you guys want the notes, then you can just let me know. And I will share my notes only with those who actually want it because that's not the main source where you have to study from. That's I made it for my say easiness so I can do a quick revision from there. But everyone has a different way of studying and you can do for yourself. It's your own ways to study. So that's what I'm saying. Whenever we are studying or you yourself is studying, always write down the important notes on the side and then you can always reread those ones. It's very easy. That's how I do. When I do the revision, I don't read the full topic. I have my few lines picked up from that topic on the side and I will reread those ones. And it do help me a lot, save time, and I can do a lot of revision. So, you when you get familiarized with Toronto notes, you do get to know which one is important, which one is not important. There is so many written here. And if you read two times Toronto notes, by the third time, you will be able to understand what they because they're writing down everything so you have an idea because this can be used on later on times when you're doing residency you feel like reading something so Toronto notes is something that can help you in that way too. So but this is not something that you can be like reading it over the time, so that's why the notes are there that will help you eventually later on for CCFP exam if you want to work independently and all of those times. So that's why it's just to save time. Do have your own notes too. Maybe like highlighted those lines or whatever it you find convenient. Okay. Now we are talking about the clinical diagnosis, finding, and suggestive diagnostic approach based on the age. The neonates, which has bilus vomiting and non-bilus vomiting. Then the clinical findings. Why we are talking about clinical findings? Because the clinical findings can be given and asked you to make the diagnosis. Okay, this can help you more than enough to go for the gastrointestinal diseases for the pediatrics. If there is a excessive secretion, choking, respiratory symptoms is there, then think of some trachea is involved. So it's a tracheoesophageal fistula. Whatever you are eating is going into trachea that causes choking and respiratory symptoms. Pyloric stenosis, it's like a after 30 minutes, they are having a non-bilious vomiting and then vomit falls away, a little bit away from your clothes or shirt, and then palpable olive like in the upper quadrant. And there is always hunger, whatever he eats, because it comes out in 30 minutes. So that's why. In GERD, there is fussiness, spits up, arcing of the back. Very, very, very important. Arcing of the back is there in GERD. Highlight this word, and it is if they are giving you a scenario of GERD, the arcing of backboard will be there, especially for neonates. In sepsis, fever, lethargy, tachycardia, tachypnea, widening pulse pressure. Then in inborn error, usually the poor feeding, failure to thrive, jaundice, hepatosplenomegaly, cardiomyopathy, then developmental delay. Neonate with the bilus vomiting, intestinal obstruction is there. In this one is the black stool, pain with bloody stool, shock, abdominal distension. So you feel like there is obstruction. Then the duodenal atresia, in this one, there is bilus. The pyloric one, there is no bilus, although the vomiting comes out the same. But in the duodenal one, the most important is hypokalemia, and it's very very common in the polyhydramnios. So the word polyhydramnios is important, highlight this one. Then come the Hirschsprung disease. In this one is pain, failure to pass the stool. Okay, so they will be unable to pass the stool and later can change to toxic megacolon and all this one. So there is bilus misses. In Hirschsprung, not able to feed and not able to pass the stool. Necrotizing enterocolitis, in this one is also changed to the toxic megacolon. So in this one, you have to see how does the picture look like, the air fluids level. Okay, that's more important. They do give the X-ray for that. Premature neonate, bilus, MSAs, bloody stool is there, intolerance to feed, creatinine, bun, and blood cultures. Then comes the viral gastroenteritis. In this one, the recent travel history will be given. Okay, abdominal discomfort, sick contact. Then appendicitis, in this one is right upper quadrant, and you know how does it present. Intussusception, colicky, progressive pain, along with the red currant jelly. And one more important word, drawing of the legs up to the chest. This is the line they will give you if they are looking for intussusception. Then the non-GI infection in the meningitis, like a fever and localized causes. Then increased ICP is basically headaches. It's the vomiting that's mainly in the morning time. Well, salva, and then the focal neurological gait disturbance could be there. Then the toxic ingestion, where there's history of there was a something spilled on his shirt, or he was playing with the medicines, something like that. They can give you that. This can give you that this is toxic ingestion. Pregnancy is amenorrhea and all that. Cyclic vomiting that comes and goes, comes and goes. So basically, minimal episodes of vomiting is there, lasting 12 hours. Mainly go for rehydration. And then trying the antiemetics, which antiemetics? Olenstrone, promethazone, and then when we will do obstetrics, we will do from there. Okay. So I think that's about it. We will start from here. Do read a lot of them. Do solve from that rehydration chapter. Okay. I will try to find my notes from the pediatrics, and tomorrow we will start from there if I find something. And first we do those ones, and then we'll restart from here. Okay. If you have any question, do let me know. Do give it a quick read. Do a lot of solving of the scenarios, like especially the fluid status, how you are going to do it. It's important. Okay.
Thank you.